You know that old pop culture cliche, right? The quiet doctor sitting behind a leather couch, just kind of nodding while you talk about your childhood for an hour? Well, forget all that. The reality of modern psychiatry is actually far more dynamic and honestly deeply fascinating. Welcome to this explainer. Today we're going to completely unpack the psychiatric assessment. It's definitely not just a casual conversation. It is a rigorous, highly structured, three-part scientific toolkit used by clinical detectives to literally map the human mind. We're going to look at exactly how these professionals gather clues, analyze behavior, and use incredibly specialized communication strategies to figure out what's happening inside a patient's brain. Okay, let's dive into this. Here is our roadmap for today. Number 1, taking the patient's history. Number 2, the mental state examination. Number 3, analyzing thoughts and perceptions. 4, assessing cognition and judgment. And finally, 5, the art of the interview.
So, Section 1, taking the patient's history, setting the foundation.
Before a clinician can even begin to analyze the present, they absolutely have to understand the past. But look, it's not just about pulling up medical records. First things first, they have to establish a safe, comfortable environment built entirely on consent and confidentiality. Once that trust is set, the investigation follows a really logical progression. We start with basic socio-demographics, things like age, occupation, who they live with. Then we get to the chief complaint. This is always initiated with an open-ended question to capture the patient's primary struggle in their very own words. From there, the clinician traces what's called the history of present illness, or HOPI. At this stage, they're basically acting like a journalist. They're looking for the exact onset, the duration, precipitating factors, and any associated symptoms to build a really comprehensive timeline of the current crisis. Now, what's really fascinating here is this concept of the pre-morbid personality. This asks a pretty critical question. Who was this person before the illness actually took hold? You see, a mental disorder doesn't just erase who you are. The symptoms are actually modified by your baseline personality. So understanding who the patient was before all of this helps the doctor predict the prognosis, and it separates the actual disease symptoms from the person's natural, everyday character traits. Moving right along to Section 2, the mental state examination. If the history taking was the background check, the mental state examination, or the MSC as it's called, is the active crime scene analysis. We shift entirely from the past to right here, right now. The clinician is immediately scanning for external clues. They're looking at appearance. Does the patient actually look their age? Are there visible scars or signs of self-mutilation? How's their general grooming? Then they look at behavior. Are they sociable or maybe hostile, defensive, or even completely bizarre? Is their physical movement, their psychomotor activity, hyperactive or unusually slowed down? And then, of course, their speech. The doctor isn't just listening to what is being said, but exactly how it's being said. They're checking the volume, the rate of speech, the articulation, and the latency. Latency is basically how long it takes for the patient to actually start answering the question after it's been asked.
And this brilliantly illustrates one of the most common misunderstandings in psychology, the difference between mood and affect. Think of mood as the overall climate. It's the patient's internal, subjective, long-lasting emotional state, like being universally depressed or manic. Affect, on the other hand, is the weather. It is strictly what the doctor objectively observes in the room at that exact moment. Is the patient's emotional expression flat? Is it labile, meaning, it swings wildly back and forth? And most importantly, does their outward expression actually match their internal mood?
Let's look at Section 3, analyzing thoughts and perceptions. So sometimes the very structure of a person's thinking breaks down. Clinically, this is known as a formal thought disorder. Take tangentiality, for example. The patient is engaged in the conversation. They clearly hear your question, but their mind just wanders off on a tangent, and the point is simply never reached. You never get the answer. This is pretty distinct from something called circumstantiality. With circumstantiality, a patient might give you a dozen unnecessary, trivial details, but eventually they do circle back and actually answer the question. In tangentiality, the destination is completely lost.
Beyond just the structure of thought, doctors have to examine the content of thought. Specifically, they're looking for delusions. And delusions take many forms. You've got persecutory delusions, where the patient believes intelligence agencies, or maybe even just their neighbors, are actively plotting against them. Then there are referential delusions. This is where a patient might see a random reel on Facebook or a news report on TV and genuinely believe it is a secret message aimed specifically at them. Grandiose delusions involve beliefs of having special powers or some kind of divine status. And then nihilistic delusions. These are deeply physical. A patient might actually believe their intestines have completely stopped working, or, in extreme cases, that they are already dead.
To make this super concrete, imagine sitting across from a patient and they tell you in total seriousness, "I am a prophet and I have discovered the cure for all diseases." This perfectly captures a grandiose delusion. But here is the absolute key thing you must remember. A delusion is a fixed, unshakable, false belief. It literally cannot be rationalized away. Even if the doctor presents overwhelming, undeniable contradictory evidence, the patient's mind will not and actually cannot change its stance. Moving from thoughts to perceptions, we have to talk about hallucinations. A hallucination is a completely new perception that occurs without any external sensory stimulus whatsoever. Think of it like hearing a voice when the room is entirely silent. Now, this is very different from an illusion, which is an inaccurate perception of something that's actually real, like seeing a coat rack in a dark room and jumping because you thought it was a person. There are also pseudo-hallucinations. These occur in the subjective inner space of the mind, but crucially, the patient retains insight. They know the voice or the image isn't actually real.
Section 4. Assessing cognition and judgment.
So to test the brain's operational hardware, the clinician uses a very systematic sequence of tests. They start with the absolute basics, level of consciousness and orientation. Does the patient know exactly who they are, where they are, and what today's date is? Then they test attention. They often do this by asking the patient to subtract 7 from 100, and just keep subtracting 7 from each new number. They test memory, moving from immediate recall of a few random numbers to recent events like what they eat for dinner, all the way back to their remote personal history. They'll even test abstract reasoning. They might ask the patient to interpret a common proverb just to see if their thinking is flexible and abstract or if it's rigidly concrete.
Okay, so the doctor knows the brain's raw hardware is working properly. But how do they know the patient is actually capable of making good decisions? Well, this introduces the concepts of judgment and insight. Judgment is essentially the capacity to act in a socially appropriate manner and make sound life choices. Insight, which is absolutely crucial in psychiatry, is the patient's own awareness of their condition. Do they have full insight, realizing they're unwell and need help? Or do they have zero insight, completely believing their hallucinations are absolute reality?
Finally, Section 5. The art of the interview.
So how on earth does a clinician extract all of this incredibly dense, highly personal, and sometimes totally disjointed information in just a single session? They use a toolkit divided into distinct psychological strategies. They use non-directive techniques, like open questions and encouraging nods, to just let the patient lead the way. When they really need to take control, they use directive techniques, like gentle redirection or even strict limit setting for patients who simply won't stop talking. To dig a little deeper, they use eliciting techniques. This could be a mild confrontation pointing out a contradiction in their story, or even the strategic use of absolute silence to compel the patient to fill the awkward void. Finally, doctors must actively avoid obstructive techniques, things like suggestive questions or showing blatant disapproval, because that will immediately shut down any real information sharing.
Let's see how this builds into their overall questioning strategy. Doctors are constantly doing this dance between open and closed-ended questions. Open-ended questions produce highly informative, wonderfully spontaneous answers. But they aren't very time-efficient and they have lower reliability simply because the patient might just ramble on. Closed-ended questions, however, yield very short, specific answers. They are incredibly precise, highly reliable, and they allow the doctor to cover a massive amount of diagnostic ground really quickly. Mastering the seamless switch between these two, that is the true art of the clinical interview.
We have journeyed through the entire psychiatric assessment today, from the foundational history and the meticulous observation of the mental state exam, all the way to the deep analysis of delusions, cognitive testing, and finally, the highly strategic art of the interview. Now, I want you to think about your own life. How might recognizing these specific communication techniques, like understanding the sheer power of strategic silence or the difference between open and closed questions, change the way you interact with people in your daily conversations? Are you truly observing the affect of the people around you, or are you just listening to their words? Keep that in mind the next time you really need to understand someone. Thanks for joining me on this explainer, and keep questioning the world around you.